Okay, hi.
Hi.
I'm Brendan Shannon, thanks. I work at Harborview, where we have a kidney genetics clinic in cooperation with Sirsek Champersard, who's a medical geneticist, and Brian Lynch, who is a genetic counselor. And I wanted to talk today about a case that, or the talk today was inspired by a case that we saw along with Francis that was sent by Sarah Sangavi. And so the outline for my talk, I'll start with a review of the case and see how it is, see if it's possible to shoehorn it into the various diagnostic categories based on clinical criteria, and then briefly touch on the inheritance patterns and how the genetics of Alpert syndrome inform that. Move to how this case illustrates the importance of genetic testing really in refining the diagnosis, and especially in informing the risk factors, the risk for family members, and then also how it illustrates the shortcomings in our current terminology that we use in describing Alpert syndrome, especially in the category of autosomal dominant Alpert syndrome. And then as a postscript, I wanted to touch on some aspects of therapy, or a specific aspect of therapy that's likely going to become relevant in the next year as a drug is kind of likely to be approved for Alpert syndrome. So our case was a 63-year-old man that had been referred for CKD. He had microscopic hematuria going back to age 13. He had a negative cystoscopy in 2018. His creatinine had ranged from 1.4 to 1.7 for at least 5 years. He had mildly elevated urine protein excretion and slightly increased albuminuria as well. His past medical history was pretty limited to just the CKD, which to that point had been attributed to hypertension and previous use of NSAIDs. He had some tinnitus, which accounted for his 10% military service disability. Social history is notable for never having smoked. He worked as a hardwood flooring installer, which if you've ever been around that involves the use of pretty loud pneumatic hammers, and also was a machine gunner in the Marine Corps Reserve. So in other words, had sort of the equivalent of auditory stress tests through most of his adulthood. His family history was a bit limited because he was adopted, but he was aware that his father, his birth father, had a kidney transplant without any further details on that. He has two daughters. One of those has microscopic hematuria and has a son. And the daughter with hematuria also has two sons. His exam really was pretty unremarkable. His blood pressure was well controlled on a low dose of losartan, otherwise pretty unremarkable. His labs this time showed his creatinine was a little bit higher compared to his previous baseline at 1.9. His urinalysis was, as it had been through his entire life, with 2+ blood and about 5 red cells per high-powered field. Some of them looked like this. His kidney ultrasound was unremarkable. So you underwent a kidney biopsy, mostly prompted by the family history, I think, and the fact that his creatinine was a little higher and some discomfort with the concept of hypertension as a cause for his CKD. So most of his glomeruli on light microscopy looked quite unremarkable, but there were a few where there were these areas where the capillary loops were not exactly sclerosed, but there were definite areas of thickening in the GBM. And on electron microscopy, he had segmental areas where the GBM looked fairly thinned, and then also segmental areas where it was thickened. And overall, the mean thickness of the basement membrane was 252 nanometers, whereas the most commonly accepted cutoff for thin basement membrane nephropathy is less than 250, so pretty close. But then there were these segmental areas where things were quite thickened, where there were areas of splitting, and where you had these basket weave appearance that we normally associate with Alpert syndrome. So based on clinical criteria and the pathological criteria, what is his diagnosis? Does he have Alpert syndrome? Do we call this thin basement membrane nephropathy? So factors in the family history that would favor Alpert syndrome is if there is a family history of Alpert syndrome without another cause of hematuria, making that highly likely. It doesn't quite fit with that because we lack details on his father. Things favoring thin basement membrane nephropathy would be the opposite. If there is no family history, we can't quite apply that to him given his father's history. And then the clinical features, if there are these extra-renal features like hearing loss, or the specific ocular features like lenticomnus or some of the retinal findings, that would highly favor Alpert syndrome. If those are lacking, that would more favor thin basement membrane nephropathy. And then in terms of pathology, if there's diffuse areas of the GBM lamellation, that is considered generally pathognomonic for Alpert syndrome. And if there are diffuse areas of GBM thinning without the splitting and lamellation, then that makes thin basement membrane nephropathy more likely. So he doesn't fit into either of these categories either, because he has segmental areas of thinning, segmental areas of the lamellation. So based on the clinical and pathologic findings, his diagnosis is really unclear. So what's the next step? Before we move to that, I just want to briefly touch on the genetics of Alpert syndrome. There's 6 different genes that encode the various proteins that make up type 4 collagen. And the ones that we're interested in are the Col4A3 and Col4A4 that are located in pairs on chromosome 2 in a head-to-head fashion. And then Col4A5, it's on the X chromosome. Now, these each make an individual alpha chain that will combine inside the cell to form the mature protein that then gets secreted out and is incorporated into the basement membrane. And they wind together sort of like a 3-stranded rope. If you have a genetic variant in any one of those genes, it affects the assembly of the whole network, and it's not able to form the mature trimeric protein. It either gets degraded inside the cell or accumulates inside the cell, or maybe it has a potentially toxic effect. And the normal scenario, all of the basement membrane collagen in the 3,4,5 chain forms a nice little rope-like triple helix structure. If you have X-linked Alpert syndrome and you're a male, or autosomal recessive Alpert syndrome, where you have 2 pathogenic variants in the Col4A4 gene or 2 pathogenic variants in the Col4A3 gene, or you're a male and your 1 copy of Col4A5 is abnormal, then 100% of the 3,4,5 network that you make is abnormal, and none of it essentially gets secreted into and incorporated into the basement membrane. So the net result of that is the collagen composition is altered. And there's a lot of different experiments to show that how that manifests, but the sum result of it is that it alters the physical properties of the GBM. And this is my favorite little experiment that demonstrates that, where this group took isolated mouse glomeruli from a model of autosomal recessive Alpert syndrome, and then pressed on them this nano cantilever and measured how much the glomerulus was deflected. And the Alpert glomeruli were basically softer and more easily distensible. The result of this, weaker GBM or weaker glomerulus, after sustaining years of 140 liters of glomerular filtration, the GBM begins to break down over time, becomes scarred, and stops working, and leads to kidney failure. Now, what about the heterozygous cases where you have 1 abnormal copy of either the alpha 3 or the alpha 4 chain, or you're a female and you have only 1 of your alpha 5 copies is abnormal? In that case, then 50% of the basement membrane collagen you make is normal, 50% is abnormal. So there is a reduction in the collagen 4 network instead of an absence of the normal collagen 4 network. The consequence of that is that the GBM itself becomes thinned and is subject to microruptures that occasionally let red blood cells, pictured here, pop through the GBM. So the mode of inheritance of these various types then, of course, depends on the location of the genes. Most of what we consider Alpert syndrome is X-linked and affects males, and it's considered generally a severe disease. Over 90% of people of males that are affected developed kidney failure by age 40. Females are also affected, but it's generally less severe, where 15 to 30% will develop kidney failure by the time of age 70. Autosomal recessive Alpert syndrome, where there's 2 pathogenic variants in COL4A3 or 2 pathogenic variants in COL4A4, is less common, makes up about 14%. Now, what's more of a vague category are the heterozygous variants, and how do we describe those and classify those, where there's 1 pathogenic variant in either COL4A3 or COL4A4. There's this description of autosomal dominant Alpert syndrome that accounts for about 1% of what's considered Alpert syndrome. Heterozygous variants have been increasingly identified in FSGS, which may be present with or without the GBM abnormalities. And then, of course, thin basement membrane nephropathy. But how these 3 categories are distinguished from each other based on clinical grounds especially is definitely not clear. And there's also no clear distinction in terms of either genetics either. There's been a few papers published over the last year that is describing with a little more precision the risk for heterozygous variants. There's a systematic review recently published of 777 patients that had heterozygous COL4A3 or COL4A4 variants, and they had a 15% lifetime risk of kidney failure that developed at a median age of 55. About 15% of those that had audiometry had some form of hearing loss, and 3% had ocular findings that could be consistent with Alpert syndrome. Another study that looked at a retrospective cohort assembled from Spain looked at 252 patients that had single variants in COL4A3 or COL4A4, and they had a slightly higher risk of kidney failure, with 25% requiring renal replacement therapy, but with a similar age of onset with a median age of 55. An interesting thing that they noted was that kidney failure occurred in 40% of those that had proteinuria, but in none that lacked proteinuria. 8% of those that had, of the subset that had hearing exams, had the high tone sensorineural hearing loss that's consistent with Alpert syndrome. Only 2% had some kind of ocular finding that would be consistent with Alpert syndrome. So back to the case, for this guy, it's kind of important to really get a better definition of his diagnosis, and especially the mode of inheritance, because that really affects the risk for his family members. So this is a pedigree where squares are males and circles are females. So this is the patient. The black box in the middle indicates he's affected by something. And so at this point, let's call it hematuria. And then this is his daughter, who also has the hematuria, his son and his other daughter. So if he in fact has X-linked Alpert syndrome, the risk to his son is basically his son is scot-free because it's on the X chromosome, and his son gets the father's Y chromosome. He's not going to inherit the variant. But his 2 daughters are obligated to inherit the abnormal X chromosome. So they'll have one of their X chromosomes will have the abnormal COL4A5 gene. And then the daughter with the 2 sons, each of her sons will have a 50% probability of being affected by X-linked Alpert syndrome with a high risk of early onset kidney failure. So if it's autosomal recessive, where he has 2 defective copies of COL4A3 or 2 defective copies of COL4A4, then each of his children have 100% probability of inheriting one or the other defective genes. And then the daughter with the 2 sons each have a 50% probability of inheriting the defective gene. So if it's heterozygous and he has only 1 abnormal variant in COL4A3 or COL4A4, so let's call that autosomal dominant, then each of his children have a 50% chance of inheriting the same thing. And if the daughter ends up being affected, then her 2 sons have likewise a 50% chance of also inheriting it. So he underwent genetic testing, and lo and behold, he had a pathogenic variant in Col4A4 that had been previously published in a family with autosomal recessive Alpert syndrome. He had only a single variant in that. It was a frame shift mutation predicted to be pathogenic. But then he also had a second variant in Col4A3. Now this had not been reported before, so it was not clear as far as its pathogenicity. It was predicted to affect a splice site, so it's not entirely possible to call it benign, so it was classified as a variant of unknown significance. So his genetic testing results importantly ruled out the presence of X-linked or autosomal recessive Alpert syndrome. But it still didn't really tell us whether we should call him autosomal dominant Alpert syndrome or thin basement membrane nephropathy. And it didn't give us enough information as far as informing the risks for his family members. So it introduces a newer, I guess, concept called Digenic Alpert syndrome. And that's where there is a mutation that affects more than one alpha chain. And in theory, the severity should be intermediate between autosomal recessive or X-linked Alpert syndrome in males and the heterozygous cases. And so in this case, 25% of the collagen molecules will be normal. 25% will have an abnormal copy of the alpha-4 chain. 25% will have an abnormal copy of the alpha-3 chain. And then 25% of the collagen molecules will have abnormal copies of both alpha-3 and alpha-4. And I just want to distinguish this from autosomal recessive, because that autosomal recessive, again, involves defective copies of the same alpha chain. Whereas digenic is an abnormal copy of 2 of the 3 chains. Now, informing the risk to family members is determined by what's known as the phase, or in other words, what chromosome the genes lie on. If you remember, they're both alpha-3 and alpha-4 are on chromosome 2. So you can have what's known as digenic inheritance in cis, where they're both on the same chromosome. In that case, the mode of inheritance mimics autosomal dominant transmission, where the genes will be inherited together. So each of his offspring will have a 50% probability of inheriting both genes. And then if the daughter ends up being affected, each of her sons will have a 50% probability of also inheriting both genes. Digenic inheritance in trans is where the defective genes are on different chromosomes. And so they are inherited separately. So each of his kids has a 100% probability of inheriting one or the other, but not both. And then the grandsons will each have a 50% probability of inheriting whichever gene the mother's affected by. Now, this is important because if this is the case, then all of his offspring should, in theory, have a less severe clinical course than the index case, the grandfather here. So to resolve this, his family underwent cascade testing, where 2 of his 3 children also underwent genetic testing. The 39-year-old daughter, who, by the way, also has mild CKD with a creatinine of 1.1 and mild albuminuria, has the Col4A4 variant that's known to be pathogenic. The daughter we weren't able to contact and don't know anything about her clinical history, but the son also underwent testing, and he's completely normal, has normal kidney function, has no hematuria, and he had the Col4A3 variant. So this indicates that they're present in trans, and then also that the grandsons each have a 50% chance of inheriting the pathogenic variant. Now, this also would provide support that this is not really a case of digenic inheritance, because in that, technically speaking, both variants need to be pathogenic And this, the apparent, the course of the sun is really more consistent with this being a benign variant rather than a pathogenic variant. So it's also points out the kind of the difficulties still with nomenclature, and we still haven't really resolved that. A few years ago, there was published this proposal to redefine all of the collagen 4 disorders and call everything Alpert syndrome, and then to further specify whether it was X-linked or autosomal recessive, and then if there was just a single copy of alpha 3 or alpha 4 present, then to call that autosomal dominant Alpert syndrome, whether the person just had microscopic hematuria, had nothing, or had developed kidney failure in their lifetime, or had a family member with kidney failure. Now, one of the problems with that is that autosomal dominant Alpert syndrome is not really a syndrome, in that the phenotype is pretty much limited to the kidney. There's either extremely reduced or almost completely absent penetrance of the other extrarenal features like hearing loss that we associate with the other forms of Alpert syndrome. And then it can be kind of confusing to patients, I think, because dominant has this sort of aggressive sound, but really the risk of kidney failure is much lower than in autosomal recessive or X-linked males, like 15% versus 95%. So is that really even the same disorder? And then finally, I think there's kind of a cognitive dissonance in describing someone as having a dominant disorder, but also at the same time being a carrier for a recessive disease that, by the way, has the same name. So what are the alternatives? Can you just come up with a completely separate name and call everything Col4 nephropathy and then specify further by the mode of inheritance? Maybe, but Alpert syndrome is kind of a long established term. It's recognized by families. There's a nice foundation using that name. What about going with the idea of calling everything Alpert syndrome, but further specifying it by the mode of inheritance, including X-linked, recessive, autosomal heterozygous, and then, in some cases, digenic. I would argue that thin basement membrane nephropathy is kind of an inadequate term because it's based on histology that probably in most cases may not be done because most patients probably don't undergo kidney biopsy. And it's also not really specific to the heterozygous variants because it can be seen in either X-linked or recessive disease if the biopsy is done early enough in life. It might falsely imply a good prognosis in a condition that appears to have up to 15% risk of kidney failure. And then there's a lot of overlap with the histology and between forms that have FSGS or lamellation and splitting, like in our case. So there's not a clear distinction clinically between those categories. So to conclude, I hope this case illustrates that the genetics of Alpert syndrome and the modes of inheritance are complex. And the main reason for that is because it involves a protein product that's encoded by 3 different genes that are both autosomal and sex-linked. And then genetic testing is really required to define the diagnosis and the mode of inheritance, and then inform the risk of family members. And then it also illustrates kind of the difficulties in terminology, especially in regards to autosomal dominant Alpert syndrome, because it's confusing to patients, counselors, and clinicians. And I just want to kind of abruptly shift gears and say a few things about therapy in the last few minutes, because I think this is going to be an issue in the upcoming year. We know that ACE inhibitors are good for kidney disease. That's not a surprise. There aren't controlled trials that have been published yet in Alpert syndrome, but there's a few clever studies like this one that looked at pairs of siblings where the older sibling was diagnosed later in the course of disease, had been either not treated or only briefly treated with ACE inhibitors. And those developed kidney failure at age 27 versus the younger sibling that got earlier treatment developed kidney failure at age 40. And I know this, you can't make direct comparisons, but this feels like more than something like an 18% relative risk reduction, like in the Renal trial, for example. So it seems really that people with Alpert syndrome have sort of an exaggerated response to ACE inhibitors. So there are a lot of ads lately, the last few years, in the various journals by a company making this drug bardoxolone that is supposed to have anti-inflammatory effects by inducing NRF2 expression, which is a transcription factor that activates a lot of antioxidant genes and that limits leukocyte recruitment. Is supposed to reduce inflammation. It's also supposed to put the brakes on NF-kappa B pathways. It was first studied as a cancer drug, and it turned out it didn't really help cancer, but they did notice that it increased GFR. So it was studied in patients with diabetes. This is a trial of 150 patients that were treated for a year that had pretty advanced CKD at baseline with the GFR in around 30. And those, the placebo treated had little change in GFR, but there was this early and more or less sustained improvement in GFR that lasted for about a year. And it started as early as 4 weeks. And the difference was kind of significant, like 8 to 11 milliliters per minute over baseline. Now, they also noted there was this weak correlation between improvement in GFR and also increased albumin excretion. So it was studied in a larger group of 2,800 patients. It also showed improved GFR that was sustained for about a year. And it was, it also happened early, like within 4 weeks. But in parallel, there was a worsened albumin excretion. And then more importantly, there was an increase in cardiovascular deaths, and especially in CHF deaths and hospitalizations with a hazard ratio of like 1.8 for that. So the trials actually stopped early. I said a year, it was actually stopped after 9 months. And so the drug wasn't approved for kidney disease or for diabetic kidney disease. So why would you study this for Alpert syndrome? It turns out it hasn't been looked at in mouse models of Alpert syndrome because it's super toxic to rodents. There was a paper published just recently, a few months ago, of an analog of bardoxolone, not quite the same therapy, but it's supposed to work in the same way. It's not inherently toxic to mice, but in mice with sort of induced kidney disease. So if you gave them a nephrectomy and then gave them a constant infusion of angiotensin II, and then also gave them this drug, there was a significant increase in urine albumin excretion. It's affected histology significantly, where you see kind of normal foot processes in glomeruli in the placebo-treated mice, and diffuse foot process effacement in the ones that receive the bardoxolone analog. So bardoxolone has been studied in people, though, and a phase 2 trial showed it increased GFR by about 7 milliliters a minute after the first week, and up to 12 milliliters a minute after 3 months. And there was recently just reported the results of a phase 3 trial that showed a 7 milliliter a minute increase after 2 years. And after stopping the drug for a month, for 4 weeks, that's decreased to 4 milliliters a minute. But based on that, the company submitted an application to the FDA for a new drug application, and it was accepted, and they're supposed to rule on it by next February. And it probably has a good chance of being accepted. Now, none of this has been published. This is all just reported on the company's website, so presumably it'll be published within the next year. The drug is also being tested in PKD in a trial actually up at Swedish that's enrolling. Now, I think there's a lot of potential concerns with this, and it would appear that bardoxolone may be the mirror image of what RAS inhibition does for the kidney, and potentially could have sort of the opposite effects of what we think it's doing. So if you look at the black line, which is the natural history of progressive chronic kidney disease, and then you treat that with the RAS inhibitor, there's a immediate drop in GFR, but it reduces the slope of the rate of the decline in GFR over time. So it preserves kidney function over a greater period of time. Bardoxolone, if it induces hyperfiltration, as it appears to, will result in a rapid increase in GFR, but an increase in the slope of that decline. And so you can actually have more rapid development of kidney failure. Now, if you're capturing the point, if you're capturing, the point in time up here, like the trials have done, it still might look like you're showing benefit compared to baseline. So I think it will really require a longer period of time before we know if these drugs are safe. So I have a lot of reservation in their clinical use, but kind of seems like it might be approved. So with that, I'd like to just finish up with a view of the harbor and say thanks for your time.
Thanks so much, Brendan. I know we're a little over time, but just wanted to open it up for questions for Brendan.
Hey, Brendan, that was a nice talk. What are your thoughts about, in Alpert syndrome, the mesangial cells under the influence of endothelin-1 have these filopodia that invade the glomerular microvasculature. So giving endothelin antagonist has been shown to.
Yeah, I don't think it's been studied, but I think there's interest in using sparsentan in this group. But I'm not aware of data on that.
Brendan, any reason to believe bardoxolone is particularly useful for Alpert's based on mechanism? It seems a little bit like a drug looking for a cause.
Yeah, for sure. No, I think it's, there's, I think, a lot of reason to want to run away. I mean, the reason to use it in Alpert syndrome is because it's considered a rare disease. And so the criteria for FDA approval are a lot lower, or the threshold for FDA approval is a lot lower, similarly for PKD, I think.
Brendan, how do you describe these conditions to patients? I mean, in terms of the nomenclature, like in your own practice. Do you call it Alpert syndrome? Do you call it collagen 4 related disease?
Right. I mean, I guess with this patient and with this family, I sort of did this, I tried to like walk them through, the issues, and especially with the dominant form. So I tend to say it's Alpert syndrome and heterozygous. Because I guess at least the people that I'm seeing in the clinic are not sort of uncomplicated thin basement membrane nephropathy with isolated hematuria for the most part. But I did see a patient that was, that had genetic testing as part of carrier screening because his wife was pregnant and had undergone, she was older, so she underwent genetic testing, I guess, and had like she was a carrier for some unrelated like neuromuscular disorder. So he underwent testing, and his descriptions said that he had Alpert syndrome, and then it just sort of in fine print said that there's different forms and stuff like that. But he was really quite frightened when I saw him, and also frightened about his kid. But he had a single, variants in COL4A3.
All right. Well, thank you so much, Brendan. A wonderful talk, and thanks everyone for joining. Just as a reminder, next week, the second-year graduating adult nephrology fellows will be presenting their scholarly projects, and that is the second to last nephrology grand rounds of the academic year. So hope everyone has a great weekend. We'll see you next week.